Howdy do. Dr. Leibert here to talk about heart failure. There's some important basic understanding of cardiac physiology that you have to have in order to understand systolic and diastolic dysfunction. Look at the drawing on the screen. This little drawing helps us to understand. First, cardiac output equals heart rate times stroke volume. Cardiac output equals heart rate times stroke volume. Now, stroke volume is affected by three things: contractility, preload, and afterload. In the order I prefer: preload, contractility, afterload. Those three things determine the stroke volume. Okay. Heart rate is pretty self-explanatory. Either the heart's beating normally, or too slow, or too fast. Let's look again at preload, the volume that's entering the right side of the heart. Contractility, how strong is the heart contracting? And then the afterload, that's the resistance on the other end, the aortic end, if you will. That can be worsened by hypertension, atherosclerosis, where there's increased resistance or afterload to the amount of blood that can get out of the heart. So the cardiac output, the stroke volume, is affected by preload, how much is being dumped in, the contractility of the heart, and the resistance to the flow at the other end of the heart, the aorta. Those three things are really important to understand what we're about to talk about. Now, let's try some systolic dysfunction. Here's the input, the preload, the blue side. Then the heart, which is saggy and baggy. And then the green side here is the aorta, the outflow. This heart has been damaged by diabetes, perhaps by ongoing coronary disease with ischemia. The ejection fraction is abnormal. Instead of being 65%, it's 20%. So it's contracting very weakly. That poor old heart just doesn't have much give and go. Now look what happens. If you increase preload, you fill this old saggy, baggy heart full of fluid. We're looking at Starling's curve. This patient's heart is way over here on the right side of the curve, where the more you fill, the less contractility you get. Boy, you'd think if you'd fill it, maybe it would contract more. That's not the case. As the heart fails, if you stretch it too much, you stretch it beyond its point of no return and you lose function. That's the Frank Starling curve right there. And this heart is way at the far right side. So too much preload is not helping. It's already got contractility problems. And now add to this diabetic and hypertensive extraordinary afterload. There's lots of resistance from hypertension and atherosclerosis. Those old vessels are tiny, and it's hard to move that blood out of the heart into that high resistance afterload. So what do? Well, let's think about how we can help this systolic dysfunction. First, decrease preload. You don't want to overfill. You want to get that Frank Starling curve more, in the middle here where the big arrows are. So decrease preload. Give the patient some Lasix. That'll decrease preload. Or maybe some nitrates like Ismo or Imdur. Dilate that venous system and decrease preload. The contractility itself. Sometimes we use digoxin to improve contractility. Sometimes, if they're in the intensive care unit, we have to use dobutamine to increase contractility. Now, how about the afterload side? Wow, there's lots of choices. The ACE inhibitors are the drug of choice. They're very good at decreasing that resistance, decreasing some of the strain in that cardiac wall. Of course, they're renal protective for the diabetic. So we've decreased preload, increased contractility, and decreased afterload, less resistance. That means this stroke volume will be improved, cardiac output will be improved. Sweet. Now, how about diastolic dysfunction? Look at the difference here. See this heart? It's stiff. It's stiff and it's small. From years of untreated hypertension, this is typically an elderly patient, and their walls are so stiff that this little balloon can't do much. Now, here's the good news. Their contractility is normal. So on the echocardiogram, the ejection fraction is fine, but it's a stiff heart. So this patient needs preload. You want to make sure they get that thing filled so there's forward flow. Quite different than the systolic dysfunction. This is diastolic dysfunction. So this patient should not be on Lasix, should not be on long-term nitrates like Endure, because you decrease the preload, it doesn't fill. This poor stiff heart then has nothing for forward flow out the other end. The key to diastolic dysfunction is relaxing that stiff heart. ACE inhibitors, ARBs, angiotensin receptor blockers, beta blockers, relax that heart. Let it fill with some improved preload, and you'll get better forward flow. Now, the thing that sets these patients into failure is tachycardia. So they're maybe dehydrated, maybe you've used Lasix too long in them, and their poor heart rate's going boom, boom, boom. Well, imagine now, you can't get much preload in this stiff heart. It's going fast, and so now you can't get forward flow. Everything's backing up into the lung. The patient's in acute heart failure, back up into the lung, pulmonary edema, trouble. So the diastolic heart needs to be relaxed with a beta blocker, with an ACE inhibitor. Of course, you're treating the afterload. You're treating that hypertension the same as you would in systolic failure. But watch out, you got to have preload in these patients. They've got to have fluid in that stiff heart so there's forward flow. Relax that diastolic heart and you get better forward flow. But if you overdo, if you give them too much preload, remember Starling curve, you go from those big arrows where things are looking good off into the right side. Loss of contractility. So there is a limit to the amount of preload that will maximize their function. I hope that helps. The difference between systolic dysfunction, that poor contractile heart, and the stiff heart of diastolic dysfunction. Okay, the good news is Jesus gives us a new heart. He takes away the heart of stone, gives us a heart of flesh. Sweet. God bless you. See you next time.